Morning, everyone. So I believe I have the most difficult job for this whole 3 days that we've been here, which is to try to keep you awake to talk about billing, coding, and documentation. Doctors tend to be more analytic. They tend to be, they want to get more information from the patients. They want to know the story. The documentation side is the pain in our butts. It's the side that increases our risk for burnout. There's a lot more stresses in it. Understanding the way that the system works from the front desk to the clinical staff that accepts the patient and that evaluates the patient, to the doctor who sees the patient, and then the coders and billers who have to take that information and then get us paid. It's really important to see the whole picture, and that way, from the front side, we can document adequately so that we make sure that we're the most efficient in our billing and coding. Okay, so some of our learning objectives, we're going to identify key terminology in billing and coding, identify procedure coding, diagnostic coding, and evaluation and management codes, also called E&M codes. We're going to look at the guidelines and review diagnostic codes specific for sleep medicine. We're also going to explain the information that's required to complete insurance claims, the review process, and explain appeals and the rebilling process. Okay, so documentation is what all of the billers and the coders use to identify specific codes that relate to what is happening with the patient. These are diagnostic codes, every diagnosis that the patient has, procedure codes, the office visit, and any sort of diagnostics that you want to do, like a sleep study. So it's really important for adequate documentation so that the coding is appropriate and right, so that the insurance companies don't bug us with denials. We obtain reimbursements from the insurance companies, but also categorizing based off of a standardized criteria in ICD codes and CPT codes helps Medicare, Medicaid track and trend some of the diseases that are evolving over time, so we can adequately allocate resources to those specific places. So it helps us to understand and leads to statistics on diseases and health conditions. So, as I mentioned, there's 3 types of codes. There's procedure codes, diagnostic codes, and E&M codes. Codes for procedures like sleep tests, diagnostic codes for the patient's condition, and then procedure codes, which are most frequently used in sleep centers, and they typically bill for office visits. So, codes exist for new patients, they exist for established patients. They vary based off of the intensity of the service that's provided, and they're very diverse. Codes are standardized across the board, so hospitals, nursing facilities, and ER room visits all have their own specific E&M codes. Modifiers exist. The modifiers exist because if the service that is provided doesn't exactly meet the guidelines and criteria that is outlined in the ICD or in the CPT, then the modifiers are there. The most important one not ever to do is 52. 52 is a reduced service modifier. It means that typically a sleep study, in order for it to be full service, it has to be done for at least 6 hours. If it's done for less than 6 hours, the 52 modifier needs to be used. What does that mean? Insurance is going to pay us less. It becomes difficult with the modifiers as well, because if they might pay us less, they might not pay us at all for the service that's rendered, dependent on the insurance companies. There's a lot of variation, and so it's important to know which insurance companies cover what. And so also when we do the claims, most of the claims are done online. Claims are a way where the provider communicates with the insurance company and about the services that are provided so that they can be reimbursed. All right, so staff roles. It starts with the front desk. The front staff office is responsible for booking appointments, to book the appropriate amount of time for the patient to have an appropriate evaluation. They're also collecting a lot of data from the patient. All of their information in terms of their name, their date of birth, age, sex, the insurance that they specifically have, the group policy numbers. Then there's the clinical and professional staff who will evaluate the patient based off of our identifiable data, our blood pressure, oxygen saturation, the physical exam, the history and physical. And then the coders and billers are at the end of this road, where they take all of the documentation that we provide them with and they try to make sense of which codes are going to be able to be used in order to get the most reimbursement, the most appropriate reimbursement. So as I had mentioned, the front desk is responsible for scheduling, registration, ensuring that the insurance information is current, and that there's the proper spelling for all of the people's names, date of birth, and the policy numbers. Clinical and professional staff, they're responsible for assigning the codes based off of the service rendered. They're usually entered into the EMR, and a super bill is created. So before we had EMRs, typically every patient would have a piece of paper. The piece of paper would have the most common codes that the sleep center or the family medicine clinic would bill for. And then the doctor, after evaluating the patient, would look, check off all of the necessary codes that needed to be checked off, and then the billing and coding staff would take that super bill, use the documentation, meld the two together to see which codes actually will be billed for and paid out. The coding and billing staff, they confirm the codes that are signed by the clinical and professional staff. They submit the claims, they interact with the insurance companies, they obtain the reimbursements, and then they fight for us when we get denials. So, I believe that the coders and billers, they have the most difficult job because they're at the end of the spectrum where they've received the information after the patient has already left. There's no way to collect the data in this element. So it's really important, the coders and billers, they're challenged with having the most accurate information and the most detailed information that they can have. So they have to constantly question the accuracy of the staff at the front desk to avoid any sorts of errors that are there. They also have to question the accuracy of the clinical staff and emphasize the importance of avoiding code errors. Sometimes if a code is being used and it has specific guidelines under that code that were not documented, then likely that code is going to result in a denial or an appeal. So coders and billers, they're responsible for a wide variety of tasks which are critical to the financial viability of the practice. So how have things changed? Before, all of the codes used to vary by state. Now, HIPAA mandated that all of the codes be standardized. So we have two wonderful books that are given to us by the American Medical Association. They include procedural and diagnostic codes. It makes it easier for providers to bill a variety of different insurances because all of them use the same standard, and it's easier to bill electronically. Procedure codes are performed usually by physicians, qualified healthcare professionals, and for example, it's like a sleep study or an office visit. So, HCPCS is the Healthcare Common Procedure Coding System. It has 2 levels now. It used to have 3 levels. The first level is the CPT code book. This is the code book that in sleep medicine we use the most. And then HCPCS, the Healthcare Common Procedure Coding System, has a level 2 book which is also has more codes within it. I'll go into detail about the specific 2. There was a level 3 code book that was varying from state to state, but they got rid of that in an effort to standardize nationwide. Okay, so the CPT code structure, it's a 5-digit system. It's numeric only, and the category 1 has the most typical categories of the codes used in sleep centers. So if it starts with a 0 in the 5-digit system, it's anesthetic services. If it's 1 to 6, it's surgical services. 7, radiology. 8, pathology and lab. And 9 is going to be where we spend most of our time, which is going to be the medicine services. There are category 2 codes. Those category 2 codes are tracking codes. They're used for performance measurements. They're not used for billing and coding. They're a 4-digit system that ends with the letter F. And like I said, not used for billing. Category 3 are temporary codes that are used for emerging technology. Within the realm of sleep medicine, we're having, as Dr. Suarez mentioned, actigraphy, which is a growing field where wearable devices are becoming more and more smart. And I think Apple right now is working on being able to draw an ECG from their Apple Watch device. And as technology continues to grow, the codes are going to have to adopt adopt within the system so that they become primary billing codes. And that's the goal of the category 3. Eventually, hopefully, some of these become category 1 codes. So they're 4 digits and they follow with the letter T. So each major section has subsections. It's a very detailed book. It provides information on how to code the particular procedure, the definitions of what each code means, and then instructions for which code to use in which situation. There are unlisted codes if the guidelines if your patient's presentation or the diagnosis doesn't fall within the line of the coding. There are some unlisted codes that are available for use within each subsection. Some subsections, there's none that are used for sleep, but there are some in the neurological disorders. So, the modifiers. As I mentioned before, these are things that we typically don't want to use because it then makes it more complicated for insurance companies, and there's a huge variance amongst the different companies in what they cover. These are the 2-digit modifiers, which essentially say that the level of service that was performed was either below or different than what is written in the guidelines. So 26 is for only the physician portion of the procedure was performed. So the doctor's portion was performed. TC was that the technical portion of the procedure was performed. And 52 is the one that we never use, which means that less than the complete service or a reduced service was provided. 52 equals denial, okay? For lack of a better term. Different insurers, they accept different modifiers. So like I said, huge variance. It's better not to use them. And then for HCPCS. HCPCS was developed by CMS, the Centers for Medicare and Medicaid Services. These include all of the codes for drugs, DMEs, prosthetics, supplies, and dental services and vision services. So DMEs are the durable medical equipment that's used at home. In the sleep medicine realm, we're talking about CPAPs, BiPAPs, the oral application therapy devices. And then there's disposable items in sleep medicine as well that have specific codes. The PAP masks, the tubing, the nasal cushions and humidifiers, things that you're going to be giving the patient on a regular basis because they go bad. So the level 2 codes this is also a 5-digit system. It's a letter that's followed by 4 different numbers and is divided based on the letters. So E is DMEs, A are the medical and surgical supplies, and there's also administrative codes in there. J is drugs other than chemotherapy. Q, K, and S are temporary procedure codes. So the level 2 has something that's very interesting, is that the patient's body, the particular area in which the patient is getting a service is able to be identified using modifiers. So they can indicate if it's the left or the right side of the body, what part of the body it is. If it's the hand, which digit on the hand. If it's the toe, which digit on the toe was being treated during the procedure. But this is not typically used for sleep services. Modifiers can be interchanged between CPT and HCPCS, but insurance companies, like I said before, it's better to use no modifiers. It's better to use just in general what the codes are. Okay, so CPT codes in sleep medicine, they're usually found in the neurology and neuromuscular procedure code section, and that's within the medical section, the medicine section of the CPT code book. All of our codes, they start with 9. And within the realm of sleep medicine, the codes are 95800 to 95811. So the sleep section includes those guidelines, those specifics as to when to use which code, what are the definitions for each of these codes, and the modifiers that are inside as well. Most of the sleep codes require at least 6 hours of recording time. So if you don't get 6 hours worth of recording time, then the modifier 52 is used, and that's when you're at risk for a denial. 95805 is, as Dr. Suarez was talking about, after a sleep study is done, if the patient's at risk for narcolepsy, then MSLTs is performed, and also maintenance of wakefulness tests. 95807 is a sleep study that includes recording of different channels. The channels that are available are ventilation, respiratory effort, ECG heart rate, oxygen saturation. Dr. Suarez actually went through a bunch more. There's about 7 or 8 that can be measured. And the billing will also be related to how many of those channels you're testing. So for polysomnography, 85808 is the sleep staging with 1 to 3 of the parameters that we just mentioned. 95810 is typically the one that is billed. It's sleep staging with 4 or more additional parameters. And then 95811 will be for a follow-up. So say you send your patient for polysomnography, they get diagnosed with obstructive sleep apnea, you order a CPAP, and then it needs to be titrated. 95811 is the code that you'll use for the titration. Out-of-center sleep studies, I mentioned about actigraphy, 95803. This is a growing field. 95800 and 801 are for unattended sleep studies. Generally, insurances want you to do attended sleep studies. And 95800 is monitoring of the actual sleep time. This is important as well because you need 6 hours. If it's done without 95801, it doesn't include sleep monitoring of time. And if that's the case, it's most likely not going to be paid out by the insurance companies. 95806 is an unattended sleep study with additional recording channels that were mentioned, like before: ECG, respiration, movements, EOG. Okay, so HCPCS has its own codes for out-of-center sleep studies. So G0398 is an unattended sleep study with a minimum of 7 recording channels: EEG, EOG, EMG, ECG, airflow, respiratory effort, and oxygen saturation. G0399 is 4 recording channels with an unattended sleep test. G400 is unattended with 3 channels. So we have DME and medical supplies as well, for PAP devices, for PAP supplies, for humidification devices, and oral appliance therapies. Okay, let's go into a little diagnostic coding. Why is it important? So the common misconception is that diagnostic coding is not as important as procedure coding. It is really important for a diagnosis to be there, for accurate billing to occur. So without a proper diagnosis, you cannot justify a procedure. So if you order a polysomnography and you don't have the ICD-10 code for obstructive sleep apnea or something to justify the sleep study, likely you'll be denied for the office visit, and you'll be denied for the actual sleep study itself. It's also really important for tracking, because every time an ICD-10 code is used, it's used to track the evolution of the disease. It's used by the nation in order to see what we need to be prepared for in the future, where our resources need to be allocated. Okay, so the diagnosis and diagnostic codes. There's a primary diagnosis. It's the main reason for the patient's visit. This is the first code that you'll use. Likely your patient's going to come in with multiple diagnoses, and I'll show you an example of that at the very end. The primary diagnosis should justify the visit and should justify any sort of procedure that's performed. The diagnosis codes are codes for the patient's condition. It signifies about the signs and the symptoms, and it determines It's determined by the physician who's performing the procedure, who's ordering the procedure rather. So obstructive sleep apnea diagnosis justifies a polysomnography. So for diagnostic codes, we have two different ones that we use. Everybody usually uses ICD-10. It's the nationwide standard. And there's also the International Classification of Sleep Disorders, which also have more specific diagnostic criteria as well. In the sleep centers, the International Classification of Sleep Disorders is used. ICD-10 is a 7-character alphanumeric code. Starts out with one letter and then 2 numbers. Usually there's a period in between it, and then a subcategory, 1 number, and then subclassification of 2 numbers to further explain the manifestation, the location, the severity, and the type of injury of the disease. The alphabet the extension helps us describe the type of encounter. So this is a lot different than what ICD-9 had. It's so much more specific. Specific in that we can now say the cause of the manifestation of the disease, the location, and the severity. These are things that were not able to be mentioned in ICD-9. So this was a very good update. Code locations, manifestations, there's less redundancy. So it documents both the diagnosis and whether the injury has been examined before, and it reduces the administrative burdens, because if you're consistently billing for the same thing, you don't know if it's an initial visit or if it's a follow-up, it makes a big difference. It also introduced laterality, meaning that you can say the left or the right side of the body. You can say where specifically the infection is occurring. Substantially increases the amount of information about this diagnosis, as I mentioned to you before. Let's look at an example. So G47 is typically the ICD-10 codes for sleep disorders. G47.0 is insomnia, 0.3 sleep apnea, 0.4 is narcolepsy and cataplexy. If you go even further, 0.411 is narcolepsy with cataplexy, 419 is narcolepsy without cataplexy. So G47.4, if you were to just use that and try to bill for it, it would deny. If you use G47.41 and you tried to bill for that, it would get denied. You need to be as specific as possible when it comes to ICD-10. If it has a 9 in it, in this one it's a bad example, but typically if there's a 9 in it, like F20.9, that usually indicates unspecified. Unspecified, we don't ever use unspecified when we're billing. Unspecified within the inpatient setting will bury it will get you a denial. Within the outpatient setting, it will get you a denial or a prior authorization. So more likely than not, you want to be staying away from it and collecting the data that you need to appropriately diagnose your patient. So there are a couple of different postulates that are within the CPT and the HCPCS code also. That's a term that's used for a code that may require another code that fully describes the disease process that's in place. So G47.14, hypersomnia due to another medical condition. What's the other medical condition? You need to be able to bill for the other medical condition, like a brain tumor, in order for you to get reimbursement from the insurance companies. Code first is the underlying condition that the code is being used as the primary diagnosis. So you need the primary diagnosis first, and then the secondary code, for example, G47.37, which is central sleep apnea, in conditions classified elsewhere. Classified elsewhere means that you need to have the ICD-10 code for something like a brainstem lesion in order for you to justify that code. And then there are some codes that include certain conditions, a slew of conditions within one code. That's like F15. Other stimulant-related disorders includes amphetamine-related disorders as well as caffeine. You don't have to do any further coding from that. There are 2 types of exclusions. Excludes 1 is mutually exclusive. You can't bill for sleep apnea G47.3 and sleep apnea of a newborn P28.3. You have to be specific about which one you're billing for. They can't be coded together, mutually exclusive. And then the second one is that the code excludes a certain condition. So this is used to identify a diagnosis that's not part of the code or the category code, but it can be reported in addition. So sleep apnea, G47.3, hypersomnia, G47.1, those two things can occur together. So where are the sleep codes? They're usually in the mental, behavioral, and neurodevelopmental disorders. In F10 to F19, they're mental disorders and behavioral disorders due to psychoactive substance use. For example, F10.182 is alcohol abuse with alcohol-induced sleep disorder. F50 to 59 are behavioral syndromes associated with psychological disturbances and physical factors like F51.01, primary insomnia. And then G40 to 47 are the episodic and the paroxysmal disorders. G47.33, obstructive sleep apnea, pediatric or adult. So F10 to F19, these are the alcohol and drug-induced sleep disorders. They're found in the mental, behavioral, and neurodevelopmental disorders section of the chapter. As is mentioned, alcohol, opioids, cannabis, sedatives, hypnotics, anxiolytics, cocaine, other stimulants, example that I had mentioned from before, hallucinogens, nicotine inhalants, and other psychoactive substances. So, sleep disorders that are not due to a known substance or known physiological condition are found in the mental, behavioral, and neurodevelopmental disorders section of the chapter. So F51.0 are insomnias and hypersomnias and parasomnias. So 51 from 0 to 9. Sleep disorder 0.9, not due to a substance or known physiological condition, is billable. So G47 is in the nervous system chapter, and this is where primarily some of the sleep disorders are going to be billed. So we have G47.1 and all of the specifics of the hypersomnias. G47.2 are circadian rhythm sleep disorders. (47.3) sleep apnea. This is the most common area for billing. (47.4) narcolepsy and cataplexy. Parasomnia is 47.5. 47.6 sleep-related movement disorders. And then codes that are not found within the realm of those breakdowns will be E62, 66.2, morbid severe obesity with alveolar hypoventilation, restless leg syndrome, nocturnal enuresis, primary sleep apnea of the newborn, Cheney-Stokes breathing, and snoring. Okay, we're going to talk a little bit about E&M codes. Or Dr. Ahmed, are they bringing the lunches now? So should I break now? Continue? Okay. Okay. So E&M codes are the CPT codes that are used to describe the services that us doctors provide. They start from the patient's visit with the illness or the injury, the chief complaint. The physician takes the history, gives the physical exam, makes a decision on the course of care, and then decides on any additional tests or procedures that they might need in order to appropriately treat the patient. So 99 is where most of the billing for sleep medicine is going to be found. Within the CPT book, this is such a popular section that it is it is used it is found in the front of the book now. So the book is no longer in numeric order. It's the most commonly billed area, so they put it at the front. All right, so in general, E&M codes have a range. For a new patient, 99201 to 205 is the range, and for an established patient, 99211 to 215 are the codes that we use. The higher the code number indicates the higher the level of the service, which indicates the higher level of payment. So the difference between new patient and established patient, you would be able to tell, is the fourth digit. And the code selection is based on all of the documentation that we provide. So the documentation that's listed in the history, in the physical exam, in the assessment and plan is primarily where these codes are dictated. Now, E&M codes are found for almost every single procedure that you might be able to think of. Within the hospital setting, consultations, ER visits, critical care visits, within the nursing home, if you're providing in-home services, preventative medicine services, newborn care services, and many, many more. There are several descriptors in E&M codes. The place of the service, which would be office or emergency room within the hospital. Content, the extent or level of the service, the amount of history, the physical exam, and the medical decision making. What the nature of the problem is, how severe it is, and time. So Medicare is trying to have doctors bill based off of time. This has its advantages and its disadvantages. The advantage is that the billing becomes much easier, and the documentation that's provided is not as it's used as a supplementary, but primarily if you put in a time and you're billing based off of the time, you will get a payout. The problem is that 10 minutes with one patient does not necessarily equivalent to 10 minutes with another patient. So what this does is it stratifies the data for Medicare, but it doesn't really correlate to the amount of workload that the doctor is using. So if you're part of some of those lobbyist groups that meet for Medicare, I suggest that you lobby against time being used for billing, because it ends up paying us less for the time that we spend with our patients. Guys, food is in the back. Please feel free to grab it. I'll continue talking, if that's okay with you. Try to get you guys out of here so you can enjoy this beautiful Miami weather and the beach that's right over there. So, as I mentioned before, 99201 is a new patient, the 0, and the 99211 is an established patient. That is the major difference. And new or established is defined as if you have seen that patient within 3 years. So it also matters if you're in a group practice and you're referring within your practice. If you're from the same specialty, then the coding is different. So let's say I see a patient, I'm a brain injury neurologist specialist, and I see a patient that's having some seizures and I want to refer him to my good colleague who's specialist in seizures within the same group practice. I can bill 99201, but my colleague cannot. He has to bill 99211. So that's an important one to know within group practice as well. But the general timing is 3 years. So, like I said, E&M codes are assigned based off of whether they're new and whether they're established. And it's based on a review of the patient's documentation and determination on how extensive the level of service was. Everything that is being derived from the HPI, the physical exam, the review of systems. If it is not detailed, you will not get paid a high level, or you will not be able to assign a very good code. So each E&M code descriptor outlines specific key components that needs to be met in order to use the particular code, which we'll go through. So there are two documentation guidelines that people use, one from 1995 and from 1997. Both of them are implemented by the AMA and CMS. The information differs slightly, but both sides are generally acceptable. The 95 and 97 documentation differ in their explanation of the physical exam. So 95 includes examination of specific body areas and organ systems, whereas 97, the body areas are not established. So for example, in the realm of psychiatry, 95 doesn't need to be used, the body organ system is a whole. So 97 is appropriate to use, but you can use either or. So how do we get the highest level of care code? It's primarily based on the first three. There are 7 components, but it's primarily decided on the first 3. The history, the physical, how difficult it was to make the decision, and then counseling, coordination of care, nature of the presenting problem, and time. Again, time we want to stay away from. Oh. Don't know what happened there. It's not even here. Try to open up PowerPoint too. So the level of detail that you collect in your history of presenting illness is very, very, very important. Some of the things that you want to also consider are the safety of the patient, red flags, questions that you would typically want to ask to make sure that you have a holistic view of the patient from their HPI. And we're going to use a case to specifically, this is the first one. All right. See if I can get us back to where we were. Okay, here we are. Determining the extent of the history, it is categorized in 4 different sections. Problem-focused, expanded problem-focused, detailed, and comprehensive. So if your HPI is pretty brief, you don't have a review of systems, you don't document the past medical history, the past social history, the past family history, most likely it's a problem-focused exam that's dictated, and that will equivalent to a low code, usually 201 or 211. If you have a brief HPI or review of systems that's there and it's based off of the patient's presentation, then that has some higher power. If you have an extended HPI with a full review of systems that's documented and past relevant past medical history, past family history, and social history, it'll be a higher code. And then, like I said, the complete comprehensive is going to be something that documents everything. In this realm, EMRs have been really good. They help us to see all of those components. Every time you do a review of systems, it's always good to document positive or negatives in at least 3 things in one system. So for respiratory, if you document no cough, no wheezing, no shortness of breath, 3 will then, within one system or above, is considered to be fulfilling for one organ system. So if you do that for all of the different organ systems, then it's considered to be complete. So problem focused, it's a limited examination of this is for the physical exam. Limited examination of the affected body or the organ system. The person comes in and they have some chest pain. you evaluate their CVS component, you don't do anything else, this is pretty much going to be what it is. Expanded problem focused is going to be that you examine that area and some of the other areas that are relevant. So instead of just doing the cardiovascular exam, we do the respiratory exam as well because of the comorbidities. And detailed would be that you're doing a much more complete exam. So wherever your focus is, if it's the heart, then you also do heart, lungs, abdomen, and neurologics. And a comprehensive exam includes it all. On a new patient, it's important to have a comprehensive exam. And on a new patient, all three postulates need to be of the highest level. So all three postulates need to be considered in order for it to be decided. So on a repeat patient, on a follow-up, two of the three need to be decided upon as within the realm. So if you have a really good history of presenting illness and you've done a good review of systems and you have a little bit of past family, past social, that will work to bill at a high level, a high code for a follow-up patient. But for a new patient, it should be comprehensive. How is the medical decision making measured? Oftentimes when we get a new patient, they come in sometimes with a lot of paperwork. They come in with a history of having an ECG, having an echo. They come in with some of their old doctor's information, or if they're being referred to a sleep specialist, they're coming in with doctor's notes. Those notes will, if you need to document inside of your documentation that you are reviewing past records. And it's not good enough to just write reviewing past records. You need to say reviewed MRI, which revealed blah. Or you can say reviewed MRI, see addendum for results. And when the bill goes in, the documentation that's going to be provided is going to be your documentation from that encounter plus the documentation that you reviewed. So the number of diagnoses that you're reviewing as well. A person who comes in with sleep apnea most likely is going to have high blood pressure, is going to have diabetes, is going to have some cardiac pathology like hyperlipidemia. So you are evaluating all of those things. You are billing for the diagnostic codes for those things as well. If you do that, then it shows the level of decision making was higher. And so it's important to bill for every single comorbidity that the patient has. It increases your proof that this work was hard. You weren't just considering sleep apnea, you were considering the patient as a whole. So, the number of diagnoses is one of the postulates for medical decision making. The data that's reviewed is another postulate. And the risk for complications in morbidity and mortality. I've seen a lot of EMRs now, they have, if you put in a specific ICD code, it will auto-populate into your plan and your assessment that certain things were discussed, the risks, the benefits of a certain intervention, medications with pluses and minuses for like what the benefits are and what the side effects are. So risk of complications, the amount of data that you review, and the number of diagnoses that you put into your diagnosis. Assigning new patient E&M codes are 99201 to 205. All components must be considered, which is the history, the physical exam, and the medical decision making. So for example, 99203, you would identify a detailed history, a detailed physical exam, and the medical decision making was low complexity. So you have a young patient who comes in with sleep apnea or snoring, and you do a full physical, you do a detailed exam. He doesn't really have many signs or symptoms, but because of the snoring and because he's obese, you decide to order a sleep study. That would be a low complexity, and then we get 203. So in general, this is the way that it goes. We want to be at 99205 all day, every day. So history, physical exam, and medical decision making need to be within that realm. First patient, all three have to be considered. Follow-up patients, two of the three have to be of high complexity and comprehensive. So established patients, like I said, 99212 and 2215. 2 out of the 3 have to be met in order for you to have that. So another example descriptor, 99213, would be an expanded problem-focused history, an expanded problem-focused exam, and then, again, low complexity for medical decision-making. So 99211 is the lowest level established patient code. So this is when patients present with minimal problems that require little, if any, history, physical exam, or medical decision-making. It doesn't really rely on key components, and it describes, established patient visits that don't necessarily require a doctor. So if a patient's coming in for a flu shot, if they're coming in for a blood pressure check, in between when you've ordered the sleep study to when you get the results. You know, these are things that can be checked by a nurse, and you can code them that way. Doctors don't need to be present. So the other ancillary contributing components are the level of counseling that the patient gets, the coordination of care, and making sure that you get services for the patient, and the presenting problem in itself, and the total time that's needed to do everything that you need to do for your patient. Like I said, the first 3 are the more important ones that the decision based off the code is being made, but these are also components that help you to justify either a higher level of billing or a lower level of billing. So E&M coding based on time. 99201, the physician spends about 10 minutes performing the service. E&M codes can be assigned by time if the counseling and the coordination of care is more than 50% of the time that's spent with the patient, and it must be face-to-face. 99204 is when the patient spends 45 minutes performing the service. Like I said, this is, depending on the complexity of the patient, it doesn't really take these things into account. So this is not a trend that we want to be billing in, because if we start billing this way because it's easier, Medicare is like, okay, well then let's just make this the standard. And then the justification of why you have a higher level of care oftentimes will not be able to be had, and you're going to end up with more appeals because the level of payout that you get for billed based off of time is going to be different than billed based off of complexity. So in general, E&M documentation, the medical record needs to be complete, it needs to be legible. If it's not documented, the rationale for why you're ordering the diagnostics and other ancillary tests needs to be easily inferred based off the documentation. The past and the present diagnoses should be easily accessible to the treating physician. The appropriate level of health risk factors should be identified. Patient's progress, the response to the treatment, and the revision of the diagnosis as you continue to see this patient needs to be done. And the CPT and ICD-10 codes reported on the health insurance claim and the billing statements should be supported by the documentation with the medical record. In the case of an appeal, you're going to want to send more information to them. And by having a complete and diverse medical record, you'll get the highest level of billing that's out there. Speaking of billing, claim forms. It's really nice now because most claims are done electronically, and all standardized electronic transactions, they require a bunch of information. The patient's personal information, the insurance information, information about the patient's condition, information about the service that's provided, the provider and their information, the facility and their information. Claims form has patient information, their name, their address, phone number, birthday, relationship status, employment status, and typically a patient's signature within the file is acceptable. Like I said, their insurance information. It's very easy to make mistakes here, and if a mistake is made here, this is an automatic denial. If a G is written into the insurance policy instead of an E, an automatic denial. It doesn't even go in front of a person to be reviewed. So making sure that your front desk staff is adequately inputting the information and the name. The biggest problem with like quick returns, quick denials is the name is not appropriately documented. So if the patient has a relationship to the primary insurers, like as a spouse or as one of the kids, you need also the information for the primary patient who has the insurance. So you're required to state your employment, whether if this condition is related to a work-related injury, an auto accident, or another accident, and this helps with medical legal. It also requires you to put information about the service that's provided, the date of the current illness, the injury or the pregnancy, the history of presenting illness, the diagnosis and diagnoses. Additional information, the date of service, the place of service, the procedure code with modifiers, but we are not using modifiers, charges for each service and the total charge, days or the unit of service, how many units were provided, and then the provider's NPI and the facility's NPI. There are these things called diagnostic pointers, which link the procedure to the diagnosis and helps it to justify the medical necessity for the patient. We also include information that clarifies whether a patient can walk or can't walk as a result of the condition. This is for work-related injuries as well. It asks for dates that the patient is unable to work, his or her occupation, and it also asks for dates of hospitalization if the patient was hospitalized. As I mentioned, they require a lot of information from the provider as well. Their MPI, the doctor's MPI, the facility's MPI, and all the date, the address, the zip code, where the person's establishment is. All this information is needed. Pre-approvals. Okay, so pre-certification, pre-authorization, and predetermination are some of the primary things that a coder and a biller gets when they first submit a claim. So pre-certification is the process of confirming whether or not a test is going to be covered by the insurance. It's very good to be done. Does it make sure that if your documentation is correct, you're going to end up getting a payout. Pre-authorization has, I'm sure all of you know, and it is a big pain in the butt for most offices, is that they tend to have insurance companies that will not cover specific services as a formulary. They require the doctor to justify the medical necessity in order for them to pay for the service. And predetermination is a question of how much the insurer will pay out for this specific service that's rendered. So Medicare used to require these. Now the private insurances have gotten involved, and this is the standard of care now. This is what they're doing. So it's important for us to be wary of it. So how do we complete an electronic claim? The coding and the billing staff, they use the electronic claim system which has practice management software in it now. We no longer use the paper super bill. We're using the EMR and all of the documentation that the doctor put into the EMR in order to generate the bill. So the super bill is provided to the staff. The staff access the patient files in the software of the medical record. The staff then codes for the services that are provided, and the claim is sent out. The claim is submitted, and then the insurance, they decide on whether they're going to be paid or not paid. So there is a difference between a clean claim, a rejected claim, a pending claim, and a dirty claim. Clean claims are submitted on time, all of the information is correct, and everything submitted for the insurance company is appropriate. A rejected claim cannot be processed because there's some form of missing critical information. This is usually a problem that happens with the front staff. Something incorrect is there, so it will be rejected right away. If you have a patient who you prescribe or you order a sleep study for, and the insurance they feel like they need more information to justify allowing for the polysomnography to be done, typically they'll go pending. And pending means that it's going to be escalated to a higher level where a doctor or another healthcare professional is going to review the documentation that's provided in order to make a decision on the claim. And typically the person will either ask for more information from the facility, or they will decide on accepting or rejecting the claim. So Medicare has the categories for the claims that are not clean. I mentioned some of them: incomplete, missing information; invalid, claims that are illogical; dirty claims are the ones that are submitted with errors; and deleted claims are claims that were canceled or voided. So there are several different clearinghouses that are used by many facilities. It's a business that accepts the claims from the providers, and they're a median between the insurance companies and the providers. They take the information, they look at it in detail, and they make a decision on whether it's justified to send this to the insurance company, it's clean, or if more information is needed. It's a way to decrease the time in which you go from a submission to an approval. Clearinghouses are really good. Let's say you're in a practice, you're billing, and you notice that a lot of your claims are getting denied. Using a clearinghouse will help in that respect, because they'll be able to identify for you what area is the problem. Along the chain of command, there's a lot of things that can happen. Is it a problem in the front staff in being able to adequately take down the patient's information? Is it a problem with the documentation of the physician or the healthcare professional that more information is needed? The clearinghouses usually will take in the claims, will clean them, and then send them to the insurance companies to ensure that the payout is happening. So it's a good option to use. Some of them are monthly fees, and other ones are based on how many claims you submit to them. It's a good measure to use if you're starting up a business, or if you're in a practice that does have a lot of denials. So ERAs, electronic remittance advice. So the insurer will respond to a provider with information about the payment status using an ERA. And it's also known as an explanation of benefits. So the providers usually establish an electronic funds transfer with the insurances, and it's important to review all of the ERAs to compare the payments that you're receiving for the diagnosis that you're providing. So if you have a bunch of different diagnostic codes in there and then some procedure codes, they might pay you a certain amount for a certain amount of diagnostic codes and exclude some of those codes that you were billing for. So if the payout is less than what you had anticipated, this is why it's important to review the ERAs to see what was covered and what wasn't. And the appeals process. So this is the most variable process that exists in this realm of coding and billing. It varies from insurer to insurer. Medicare has 5 levels, and insurance companies piggyback on all of the information that Medicare usually provides. So it starts out with a peer-to-peer, where a doctor will receive a call from another physician that is employed by the insurance company. He will then discuss the case with you, or he will ask you to justify why you are ordering a specific thing. And if he's not happy with the level of detail that you provide to him or her,